name's Alan Weil. I'm Editor-in-Chief of Health Affairs. We're pleased to have you joining us today for a forum entitled The Practice of Medicine, Workplace Satisfaction in a Changing Environment. I want to give a few minutes of background before we turn over to our panelists who are going to take us through the topic and discussion. There's, of course, a lot happening in health care and health policy these days. And we're pleased that with support of the Physicians Foundation, we've been able to create a series in the journal called The Practice of Medicine, really focusing on issues of clinical practice. We're, of course, a policy journal, not a clinical journal. And so, but the policy environment in which physicians and other clinicians practice is very relevant to many things, not just workplace satisfaction, which will be our focus today, but productivity, sense of accomplishment, which is of course part of satisfaction, and many other aspects. And so we've been able to bring an empirical lens to the topic with some very interesting papers, including some looking at how changes in payment are affecting how physicians spend time, some issues around time on paperwork and computer time relative to patient care, quite a few topics that are very relevant, not just to the practice of medicine, but as I say, the relationship between policy and the practice of medicine. When it came time to pull together an event, which we're holding today, the question was what was a good topic to focus on, and we settled on workplace satisfaction. And what I like about my job and what I'm proud of at Health Affairs is when we have a topic like this, we're able to bring empirical research, which you will hear some presented today, which appears in the pages of the journal. Narrative, one of our presenters today wrote what we call Narrative Matters, which is our first-person narrative having to describing an experience related to the healthcare system, but also bringing in health policy. And of course, the policy environment in which this all happens, and we'll hear a lot about what leaders in the field are doing now to try to address concerns about workplace satisfaction. So I don't think it's a surprise to anyone in this room, if you're here, to know that there are great concerns about how changes in the practice of medicine are affecting clinician satisfaction, retention, a lot of concerns about burnout, concerns about an epidemic of suicide among early practitioners and trainees. It's not something we talk about a lot in healthcare, but that's why we need to talk about it. And so what we're going to have today is a series of presentations from people with a variety of experiences and perspectives on the topic. I'll then lead a conversation among them to go a little deeper in some of the topics they discuss, and then we'll open it up to you as well. You're going to hear first from Mark Linzer, Division Director for General Internal Medicine at Hennepin County Medical Center in Minneapolis. He's the director of their Center for Patient and Provider Experience. I've had the pleasure of singing with him while he plays guitar. That's probably not as important. But as we were discussing, just as we started today, part of the challenges around satisfaction have to do with an obsessive focus on productivity and things that don't necessarily expand the mind and soul. And so I actually think it is relevant. He had a paper in the October issue that he'll be describing. Bob Berenson, Institute Fellow at the Urban Institute, former colleague of mine when I was there, former Vice Chair of the Medicare Payment Advisory Commission, otherwise known as MedPAC. And he had a piece in our September issue discussing some of the implications for physicians having to do with the changing financial arrangements, particularly around vertical integration. Darrell Kirch is the president and CEO of the AAMC, the Association of American Medical Colleges, which represents medical schools, teaching hospitals, and academic medical societies. He's been the dean and leader of the Medical College of Georgia and Penn State's Hershey Medical Center. And he will describe, among other things, work that he has a leadership role in with the National Academy of Medicine on this topic. And Elaine Schattner is a physician, educator, and journalist. She's a patient and cancer survivor who advocates for patients' rights and informed medical decisions. She's also on the faculty at Weil Cornell Medical College, where she's taught medical students, residents, and fellows in hematology, oncology, and internal medicine. She had a piece in the journal, a Narrative Matters piece earlier this year. So with that, to kick us off, I'll turn it over first to Mark.
Thank you. Thank you, Alan, and distinguished guests and visitors and colleagues, and what a privilege it is to be here today to share some of our work. So we've been measuring, as part of our research group, satisfaction, stress, and burnout for the past 20 years in physicians. And lately, maybe in the last 3 or 4 years, we have noticed, and many others have reported, that burnout is rising. Symptoms are now present in over half of U.S. physicians. So it's become what's known as the epidemic of clinician burnout, and the question comes, what can we do about it? Physician offices are often chaotic. We've reported that 40% of primary care offices are in a phase of chaos when you work there. The electronic medical record is incredibly challenging. And as many of us as patients may know, it seems to interfere in getting connected with your physician. And many clinicians, as Tate Shanafelt and Krasinski recently reported, intend to leave their practices or leave medicine altogether. So we did a randomized trial, a large national study supported by the Agency for Healthcare Research and Quality, of 34 practices, 168 doctors, and about 1,000 patients. We identified what made practice more satisfying, and we also studied outcomes for the clinicians and patients of improving satisfaction over time. So first we found that at baseline, clinician satisfaction was associated with less chaos, a slower, more reasonable work pace, greater values alignment between clinicians and their leaders, more collegiality between providers, and that interventions with workflow redesign or improving communication between provider groups were particularly effective at improving satisfaction. So there are ways to predict a satisfying environment, and there are ways to intervene to make one more satisfying. We then found that if satisfaction improved over about a 12-month time frame, that burnout decreased by a factor of 3, and that clinicians were 8 times more likely to stay with their practices. So a rather dramatic improvement in clinician outcomes that matter. Doctors would stay with their patients, and they wouldn't burn out. There was no impact seen on the quality of care for the patients in the study with diabetes or high blood pressure. So improving satisfaction was highly effective at reducing burnout and improving retention. But how to improve quality through work condition intervention remains to be determined. So where does that take us? The structure of the work environment for physicians matters. And burnout can be reduced and retention improved by addressing this.
So no slides for me. My challenge was in my 7 minutes or whatever I've got here, maybe 5, something like that, to both summarize my article, but also to be relevant to the topic of the day, which is patient satisfaction or lack thereof. I spent the first 20 years of my professional career in and around practicing medicine. I was a general internist, practiced actually on Capitol Hill across from the Eastern Market. And in retrospect, well, it's not even just retrospect. Even at the time, I was feeling burnout and left and became a policy wonk. I'm in the swamp. I'm in the policy swamp right now. And Health Affairs asked me to write a piece about a physician's view of vertical integration. So very quickly, I will summarize some of the points I made, which I think are relevant to this whole topic of physician satisfaction. I'll try to make some of the connections. First, I hang out with policy wonks a lot, as I've said, and there's just been a whole spate of articles recently about vertical integration, no evidence of improved quality, although I would say the studies aren't robust, but definite information about raising costs and largely about raising prices. What's rarely mentioned, and I think this is relevant to the profession, if not to individual physicians, is that vertically integrated organizations see low-income people. They see Medicaid people. Private docs don't. So for the profession, I think it is a good thing to be in an organization in which you will see all members of society, not just those who have the best insurance. That doesn't get enough attention, so I raised that first in a physician's view of vertical integration. But now let me go to some of the things that disturb me a little bit. Number one is around compensation. And that is that from the surveys I reviewed, the compensation surveys, some of which are focused on hospital-based physicians and others on independent physicians, and then some in the middle, it looks like the ratio of payment to procedural specialists exceeds primary care specialists the same across the board. Vertically integrated organizations have not changed the focus of compensation, even as many of them seem sincerely interested in moving to ACOs, which I think most people would acknowledge need to have a strong primary care base. And I think vertically integrated organizations have, frankly, been too complacent about the distortions in the physician fee schedule that produces too many procedures and tests and not enough time spent with patients. So I found that disappointing. In 30 seconds, I won't do justice to the topic of autonomy versus support for better care. I think that is a tension between independent docs who are autonomous, systems that can support them, which can come and do come from many integrated systems. Actually, I left one thing over here, which I need. And the issue here around autonomy, I just want to quote from Victor Fuchs, who's the smartest guy I know in healthcare, from, I think this is 1997 in a JAMA article. The ascendancy of managed care and the concomitant stampede to consolidation of healthcare organizations through mergers and acquisitions are transforming the body and soul of American medicine. Now, that was 20 years ago he wrote that. And I don't think I sense that the transformation has occurred in the body and soul of American medicine, but we don't know a lot about that. There really hasn't been a lot of follow-up. And for my article, I found some journalism, some good journalism, sort of documenting changes. I would refer people to Larry Casalino's article in Health Affairs in August about the corporate nature of practice, but it is an understudied area. Clearly, the ideal model would build on the best of small practice, which is around relationships. And after all, the evidence does show that the smallest practices get the best results on some very important outcomes like lower rates of avoidable hospitalizations. And yet, large organizations can provide a lot of system support, which physicians would like to participate in if they felt that they weren't losing control over their own lives and practice. And let me then move towards the finish line. Two policy observations, since I am a policy guy. Number one, with vertical integration, volume-based payment and vertical integration is a combustible mix. Whether it's called fee-for-service or whatever, it generates lots of high prices and it generates lots of unnecessary volume. So if we are going to a world of vertical integration, which I believe we are, because largely physician dissatisfaction with the alternative, we need to move more expeditiously than we are moving to at least two-sided risk arrangements. And then second, we do have a problem of oligopolies. I read in a newspaper article when I was called by a reporter last week to comment on UPMC, the University of Pittsburgh Medical Center's new building, $2 billion of new construction. And the quote from the CEO was, "We want to be the Amazon of healthcare." The crucial difference is that Amazon's got some competitors. And we do not, we are moving to non-competitive healthcare systems. I am very nervous about people who want to become the Amazon of healthcare in a non-competitive market environment. So let me finish with just a couple of comments about physician satisfaction. You've heard the metaphor about physicians being hamsters on a treadmill. It was in 2000. It was in the British Medical Journal. It was actually written by Ian Morrison, who I'm sure some of you know, who's a futurist, like he calls himself, in Palo Alto. So point number one, this was in 2000, before EHRs, before a lot of the current stuff. His actual quote was, "Across the globe, doctors are miserable because they feel like hamsters on a treadmill." Point number two, it's across the globe. This isn't just a US phenomenon. We like to focus on what's particularly unique about our dysfunctional healthcare system. This is across the globe. And he also said doctors. He didn't say primary care physicians. So there's a general problem here. And so where I close the article, and I'll close my talk right now, is with this kind of a paradox, which is that vertical integration requires more active involvement of practicing physicians in innovation, in leadership, in management, in trying to convert sort of a cottage industry focus method of caring for people into something that is relevant for today. And at the same time, physicians want to drop out. Lifestyle is more important. One of the responses to being unhappy is to try to get shift work, not to be up all night, not to be responsible, check in at 8 in the morning, check out at 8 that evening, have 2 days off. So residents are going into emergency medicine, they're going into hospitalists, they're not going, internal medicine residents are not going into primary care practices. And so we have this phenomenon of doctors who are unhappy across the globe trying to sort of protect themselves. And vertical integration really does require much more active involvement in after-hours participation to try to get it better. So I'll stop. Thank you.
So I think we've heard from Bob Berenson just a terrific picture of the massive forces that are at work. I would like to start off. My goal is to talk about the way forward, but I want to start off with some reflections. So I happen to train in psychiatry, and early in my psychiatric career, I frequently saw medical students, residents, and practicing physicians who not only were suffering from the syndrome of burnout, but had traveled down the short path from burnout to depression to suicidality. This problem, we need to acknowledge, has existed for a long time. In a moment, I'll return to why I think this particular moment in time is an opportunity for us to finally acknowledge the issue and deal with it definitively. So in 2016, after a series of conversations with Victor Zhao, who's the head of the National Academy of Medicine, as you know, we held a planning meeting of a group of people from specialty societies, not just medicine, also nursing, hospital leaders, and others, to talk about whether we could take this on in the manner that the Academy does as a national issue. And Victor was very supportive of that. And we had our first formal meeting last December, so almost a year ago now. And what was interesting was the progression in just the span of that single meeting. It started off with the default position of a lot of the attendees being that the problem was the electronic health record. And that if the electronic health record could become more user-friendly and more relevant to clinical practice, things would change rapidly. About at the midpoint of the meeting, we began to realize it is not that simple. That's not to say the EHR isn't one factor among many, but there are these complex elements in the work environment, as were discussed by Dr. Linzer, and in the learning environment that are specific to trainees, medical students, residents, other health professions students, and that there also is a complex mix of personal and professional issues. So the net result of that discussion was the Academy set up 4 working groups. One that has published a perspective paper that I recommend to you. It's on the Academy's website, sort of giving the state of the research base around burnout, depression, and suicide, and talking about what metrics are perhaps best to measure these phenomena, as well as what are the gaps in research, what don't we know. One of the areas, for example, that where there's a huge gap in research is what is the state of burnout, depression, suicide for minority physicians who often will talk about the minority tax, that as a minority within their organization, they're often asked to serve on every committee, be part of every search, the extra burdens that can be placed on them, not just through conscious and unconscious bias, but these other things. A second group focused on the conceptual model, a third group on external factors and workflow, and the last group is really how do we mount what essentially is a national campaign. If you're interested in the initiative, the web link at the Academy's website is there. This is the current state of the conceptual model to illustrate how far from simple this issue is. I'm not going to go through this, but you see that there are 8 domains arrayed around this issue of clinician well-being, and they range from things like the electronic health record to the unfortunate fact that there are still state licensure bodies that ask broad and inappropriate questions about mental health histories of physicians in becoming licensed. 2 personal factors. These work groups are moving ahead, and when we look for a model for how this journey might proceed, we've talked a lot about what happened in quality and the Academy's role, then the Institute of Medicine's role in quality and patient safety. I was, like every other physician, stunned to read To Err Is Human, and I went through the stage of denial, the data can't be right. But then, like I think the profession in general, we began to take patient safety and quality seriously. And Crossing the Quality Chasm, the follow-up report, gave us a kind of conceptual map to work on. And now, when I was early in my career, every hospital had an infection control committee, a P&T committee, but you really didn't see chief quality officers. Now every health system has a chief quality officer, and people are engaged in it. And in line with one of the points Dr. Berenson made, these efforts are physician-led, and they're most successful when they're physician-led. The way forward, I think, is going to be a combination of global and local action. The Academy, I think, is the proper platform to take this on for the health professions in general, to help us have a common understanding, to look at the issue of metrics. I think if most people in the room would acknowledge that one of the problems in the quality work we've done is having too many measures and not enough measures that matter. We want to, in this area of physician satisfaction, really focus on measures that matter. I believe that at the system level, tone at the top matters, and health system CEOs, medical school deans, nursing deans, and others need to make this part of their agenda. You may have seen that Stanford recently appointed Dr. Tate Shanafelt, who's one of the researchers in this area, as Stanford Medicine's first chief wellness officer. And now I've learned about a half dozen other positions being created like this to focus on well-being of the clinical staff and other staff in the health system. I talked about measurement. I think there's a limit, though, to what you can do in terms of system-wide initiatives. I think conditions in the NICU are very different from conditions in the primary care clinic. So a lot of it will have to go down to, as Dr. Linzer pointed out, specific activities in the work unit. And the last area is going to require, I think, a lot of introspection for the health professions. I think most people chose careers in healthcare because of the image of giving care, not needing care. And in a sense, it caused us to be far too reluctant to seek out help when we in fact needed it. It's an issue of our self-image combined with, unfortunately, the high degree of societal stigma that still remains about help seeking with stress and mental distress. This is going to be a journey. We're now 18 years after To Err Is Human. I hope we are a lot farther down the road in 18 years, but none of us believe that there's going to be a quick solution in this. It's going to require concerted action at all levels. Thank you.
All right, I'm Elaine Schattner. I'm speaking primarily as a patient. Thank you. All right, better. So I speak today primarily as a patient, but also as a physician who practiced for many years. And this is my first time telling this story out loud in a public place, and I'm going to try and do that succinctly because I think it doesn't matter so much about my career. What matters is the health of other patients and the well-being of doctors so that they can, after all this training, take care of other patients and not drop out of the workforce. So I'll start with a declarative statement that healthy and experienced doctors are good for patients. Some people would argue we should have a randomized trial. I don't care. I know that my health that I have been saved by my doctors, some of whom are young and residents, and many of whom are old and experienced and have helped save my life. Next slide, please. Is there a... Gotcha. So my story, in approximately 2 minutes, is that I loved my work. I was a highly motivated doctor. And I don't think I experienced burnout. I'll get to the difference. I became depressed, and that ultimately is what killed my career. Because I have not practiced since December of 2006, I am free to speak about my mental illness. At the time when I was sick, I couldn't tell my supervisors that I needed to go to an appointment, and I missed those appointments. But the basics, and my story is complicated, which makes it hard to tell. As a child, I had and I have scoliosis. I have an S-shaped spine. It was said to be a very severe case. I and my parents were told that in order for me to walk and to bear children, I would need to have my spine fused. So after wearing a brace that didn't work at age 14, I was hospitalized. A 14-inch rod of steel was fused to my spine. It was complicated by a blood clot. I wore a body cast for 10 months, and then I moved on. I went to med school. I met my future husband. I biked. I bore 2 children. At age 33, I joined the faculty at Cornell after 11 years of training and 15 years if you count college. I was a highly educated woman, and I worked really hard, and I loved it. I live in Manhattan in a community where a lot of moms work, and so I had the support of my family. My sons took pride in my being a physician. My mom's a doctor. My mom does cancer research. You know, it wasn't that I wanted to be home. I actually wanted to be at the lab more than I would admit. I used to sneak in after they would go back to sleep. That was the kind of doctor I was, and I would also call my patients back. I had a clinic, but I took it very seriously, I guess maybe because of my experiences. Anyway, at age 38, I started experiencing back pain. No surprise. I started swimming, but but I didn't want to deal with it. I was under a lot of pressure at work. We heard about the systems, and I had only one NIH grant and I needed another. We had trouble publishing our data, which were true for the most part, but no one believed us. We were up against some big labs, etc. The grant was not renewed. I didn't get tenure. And between the ages of 42 and 46, I experienced those professional setbacks in context of some very serious personal physical setbacks. So I had breast cancer, which was discovered incidentally. It was a stage 1 tumor, and I chose the minimal amount of chemotherapy that was needed to reduce the risk of recurrence. There were no ways then of telling, as there are now. After that, and during the chemo, while walking to a pool to swim, I fell on my back and broke my right arm. It turned out I had osteoporosis. All right. I was a walking nightmare, one of my friends who is a judge said. Then I had the spine surgery, which was a lengthy procedure at one of the top orthopedics hospitals in the world, and I am lucky to have the care that I did, and the reason why I look healthy as I do is because of the care I've received and the access to good care. That's a privilege. After that surgery, which involved cutting this steel rod that was fused to my spine with risk of paralysis that was not trivial, risk of death, risk of other things, I had a blood clot, I got transfusions, etc. I went home with a team of aides. I couldn't even sit up without assistance. And I was supposed to be at home for 6 to 12 months, but my division was short-staffed. I had lost my grant and I wanted to keep my job. I also loved working. I loved taking care of other people. It made me feel good. And so I went back to work. 2 women had left the division where I worked because of other issues, and they were short-staffed. Shortly after I returned to work, my division chief got a job at another place. And the new person didn't know me from before. He didn't know that I was a good clinician. All he heard were my asking for afternoons off. And basically it didn't work out. And in the end, I had been depressed before the breast cancer, I think it having to do with the pressures of my lab. When my career fell apart, I became profoundly depressed. And I don't mean to diminish the experience of burnout that's reported in residence, and you read in the news and the stock image photo. I'm not a stock image photo. I mean, I was on the roof of our building twice. I was almost institutionalized. And if you want to, destroy it, you can't go back to practicing, or at least you could not then, with that in your medical record. I was seeing a psychiatrist 2 and 3 times a week. And what kept me alive was my family and my doctors. But I was in a lot of physical pain, I was in emotional pain, and when my career ended, I felt that I had been robbed of the thing that I loved doing. And it took me a long, long time to get over that. So I think it's a shame. Also, I couldn't tell my patients, why are you stopping practice? I mean, there were legal ramifications. So I waited until, the statute of limitations was over to tell my story. And I appreciate that Health Affairs published that. But the main thing is I hope it does some good. So I have some other slides. I don't know how much time we have to go through those. I can skip through those briefly. The point is that it's not just about residents and fatigue. Doctors get sick. Oh, sorry. So older physicians now work long hours. What happened, and I had some bad luck too. In New York State, where I finished my internship in 1988, the year that interns' hours were limited. And so, as I matured, I picked up the slack as the residents and fellows signed in and out. And, I would be up there in the middle of the night. And it was crazy, and it was dangerous, in my opinion. I think that unregulated doctor's hours for surgeons and for hematologists endanger care. Try proving that. And I think the grueling workload is harmful to some physicians' health. It was to mine. And I think it diminishes the workforce. Next slide, please. Just the previous one is that doctors get sick. I think, maternity care is now something that the systems account for. There are more women physicians. But I think the issues of infectious diseases and suicide and stress-related conditions, I mean, when we worked, there were no wellness programs, but also we ate terribly. We used to eat in the hospital cafeteria and junk food. I mean, just because it was there and we were pressed for time. Next slide, please. I think it's really hard to talk about physicians' health. I mean, I received care in the places where I worked. I had no privacy. It's part of why I went online on Twitter. I mean, I had students, my students were on teams who visited me in the hospital. One of my students was doing research at the spine center in my doctor's office. How do you handle that? My colleagues became my providers, and several of my own physicians attended a lecture I gave yesterday, and that I took pride in that, but it's complicated. The whole mental illness thing is huge. We can't solve that today, but I hope that my discussion will lead to more discussion of that and policy. I think that there are insurance and malpractice concerns. As a journalist, I have been privy to stories of surgeons and others who have been unable to tell their employers about their depression and what medications they're taking. Some are very brilliant, and some maybe shouldn't be practicing. But there's a real issue. You know, House was a successful TV program, but I think in real life he wouldn't be so tolerated despite his brilliance. Next slide. I would like to make the point that depression is not the same as burnout. Many people wrote to me after my story, and some conflated the two. Both are important. I refer in this slide to the work of Tate Schoenfeld, who was mentioned earlier, and he explained to me, and I've interviewed Tate about this, that depression is manifest at home and at work, whereas burnout is really a workplace phenomenon. At work, doctors become, they can't invest their emotional energy in patients, and this happens also to teachers and other providers of, people who help people. They lose enthusiasm for what they're trying to do and stop caring. I think what happened in my case, I can't say that I wasn't burnt out. I can tell you I loved my job so much, and taking care of other people gave me joy every day, and it made me feel better about myself. It took my mind off of my own problems. And I think part of the problem was that I loved my work so much that I didn't stop. I don't think that I had burnout, but I think my colleagues were burnt out. Not all of them, some of them, and I can't prove it. But they were tired, they were overworked, the system was stressed and without slack. And that's the problem. So if a physician gets sick, if another physician gets sick, a cardiologist today, that his or her doctors, they might be nice for the first month or year, but after 3 or 4 years of illness, as I had, they say, I need to get home. I need to take a vacation. I'm sorry, but I can't cover for you, etc. I think the next one is my last slide. Please. So a system without slack. I was asked by the editor at Health Affairs to, in my piece, make suggestions, which these are. So I'm in a minority probably in this room, and it's expensive to train more doctors. But I think that doctors need to practice more slowly, to take care of themselves and to engage with their patients and to take better care of their patients. So I think that the expectations for primary care physicians to spend 15 minutes with patients is unrealistic, and then also to spend more time calling them and reading about their conditions. I think that we need to provide more support staff. A lot of the doctors who write in academic journals and speak here at health affairs events, they're privileged. They work at places like, hospitals where there are many clerks and secretaries. I got emails and letters, physical letters, from places where the hospitals are not so well staffed, where doctors do their own notes, they wheel patients to the procedures, etc. Nurse practitioners and physician's assistants can help. I do think they diminish the patient-doctor relationship, and that concerns me, that they may be overused, plus that they don't have the same knowledge and education. And I think that the future, in technology can help. I don't have an easy fix, but I think that my story reveals some of the issues for physicians who are ill. I think it's a shame. I was double board certified in hematology and medical oncology, and I really would have liked to have continued working, and my career was cut short, and I regret that. But I hope it doesn't happen to other doctors, that we need to find solutions to protect physicians' health, including mental health. So that's it. Thank you.
Well, my job is to try to weave some of this together, because we've heard some very different perspectives, but they're all critical perspectives on the issue that we're discussing today. And so I'm going to try, instead of sort of going down the line asking questions, I'm going to try to pull out a couple of themes and ask those who are willing to respond to them. Mark, you started us sort of inside the practice and inside the office. You gave a pretty light touch to what the intervention was, and I'd be interested with the others on the panel as well. We can talk policy and big picture all we want, but at the end of the day, most people who are thinking about the workplace are going to work every day and trying to figure out how to make the best of the environment that they're in. So how can we think about this from sort of the inside the walls of the practice perspective?
We published our first paper of our randomized trial in the Journal of General Internal Medicine 2015 and a follow-up study this year. In the first paper, we have a table of the interventions that work, and there's 3 columns. Each column is a type of intervention process. So the first one is workflow redesign. I'll talk about that very briefly. The second is communication improvements between provider groups. And the last is quality improvement programs that focus on chronic disease management. And all of them essentially take the load off the docs so that they can do their job of doctoring. In the workflow redesign, it mainly revolves around the work that Krasinski is doing, spectacular work at the AMA and getting medical assistants more involved in care, getting scribes involved in documentation processes, getting the doctors away from the computer and back to the patients, building the teams and the clinical teamwork, team-based care. Kevin Grumbach, Tom Bodenheimer from UCSF. This really is the wave of the future. It's no longer an individual, ruggedly individualistic physician doing the job. It is a team. And without that team, it's not doable. Communication improvements is fascinating. It was piloted and published years ago by a group out in Portland, Oregon. And they look at what's called meetings with meaning. The idea is, as several people have mentioned today, it's important to have meaning in your work. And Dr. Schattner talks about the love of the profession. But a lot of meetings are all about how are we going to see more patients in our practice? How are we going to take care of some of the problems with the practice? And you come out of those meetings feeling pretty demoralized. The meetings need to focus around the patient and why we're taking care of the patients and what are the challenges for our patients and how do we bring more patients without resources into our practices and do the work that we're here to do. And when those meetings take place, things turn around.
Be interested in others' reactions to those, what you've seen, what you've experienced, what.
My contribution will be to just point out that public policy is making it a lot worse. It's tough
I was going to
enough.
come to that next, but okay.
Well, I'm happy to wait.
Okay.
if you'd
Yeah,
like.
let's stay inside the walls first and then come
Okay.
outside.
I mean, this is how public policy
Right,
affects what's
right.
inside the
I
walls.
got you,
Okay.
I think the common thread there, though, is taking physicians from feeling isolated and powerless to feeling part of a group that has some control over their situation. I heard somebody make an observation once that I think speaks volumes. 20 or 30 or 40 years ago, physicians worked very hard and they were very stressed, but there was the doctor's lounge where they came together. There was a sense of camaraderie and shared purpose and mutual support. Now, all aspects of our society are increasingly becoming isolated. The bowling alone phenomenon, where people feel cut off, and that is causes a loss of resilience and can lead to burnout and worse.
Did I make a comment?
Yes, of course.
I think it all actually starts with socialization in medical school and residency, where physicians are supposed to be heroic, work 36 hours, never complain. One very specific thing in my practice, we were four physicians, and 2 of us got talking about the fact that we were unhappy with a third physician's coverage of our patients at night, that we thought he was sort of giving short shrift, not writing anything down in the record as to what that was all about. We had so much difficulty getting the courage to actually talk to him. It's not a sort of collegial, it's not expected. You're on your own. You're supposed to be on your own, and we finally got the courage to say we're not happy. He responded quite well to it. actually. She said, oh, I didn't realize that. But so I don't know if it's changed since I went to medical school and residency, but boy, was there this sense of you're on your own, basically, and that has to change. It has to change across physicians, but broader multidisciplinary teams, without the physician being sort of the captain of the ship. There's too much responsibility at that level.
Yeah.
Speaking of the imprinting that goes on in medical school and residency, it's no accident that my own organization and the ACGME that works with residency programs were the initial sponsors of the National Academy effort. And this is really being taken on in a very serious way. It's unfortunate that part of the driver for that were some very highly publicized resident suicides, medical student suicides, but we do need to change and are changing the learning environment, but it can all be undone if the work environment doesn't also change.
Elaine, these comments seem to align with your prescriptions. I wonder if you have that reaction.
I mean, I think all of the comments here are relevant to the physician's experience, which then affects patients' experiences. I mean, I think that's the thing. For some reason, and maybe I read the wrong newspapers, but there's not a lot of sympathy for doctors. People think like doctors all make a lot of money and we like just dump on other people and don't care. Most doctors I've worked with, and certainly the people I choose as my physicians, and I'm, again, because I have insurance, I can, and have these special relationships, I can choose my physicians, which fewer people can. People don't know their physicians, they don't feel sorry for their physicians, they don't care about their physicians' hours, and they may not recognize how long their physicians are working. I think all of the new rules and the trends among younger physicians are to take less ownership, which is a very un-PC word. But if patients, the more that we empower patients, which I think is a good thing, the less responsible physicians may feel for taking care of their patients. I mean, if patients are going to go on the internet and get information, why do I need to provide them with so much information? And, I'm not saying it's wrong for patients to get information, quite the opposite. But there's just a diminished relationship, there's diminished trust. And so I think doctors are trained basically to spend less time with patients and and that leads them to care less about their patients. If you spend less time, if you don't put an IV in your patient or draw their blood or take their blood pressure, you're going to know that patient less well. I mean, when I was a resident, I got to know some of my patients, or when I was a fellow giving chemo, I would have to put in an IV and miss and then ask again. And all that was not necessarily good in a physical way for patients, but it was good for our relationships and for my development as a physician and for explaining things, including error. All of that is gone now. I mean, doctors don't know how to take blood pressure or draw blood, but it's that time with patients that's absent. And that time, I don't know if it equates with caring, but it fosters caring, and it fosters trust, and I think it fosters better outcomes, although, as I mentioned, I think that's hard to prove. So I think we have to sort of change the whole system in a way that promotes patients and doctors communicating more and spending more time together, which is sort of the opposite of what's happening. I don't know if that answers your question, but I think it's all true, what everyone has said.
Let me use that to move in the direction that Bob was going to take us a moment ago, which is the context in which this all happens. I'm going to take up the education issue in a minute that a couple of you mentioned, but let's just talk about sort of, I think, Bob, where you were headed, which is the policy environment that makes the kinds of solutions or approaches that we've been discussing harder, and are there some that actually might make it better?
Yeah, no, I was actually going to make a very brief comment on Elaine's last comment, which is that's what her point is what bothers me about this sort of mantra, everybody has to practice at the top of their license. If physicians are spending all day being triaged, only the tough, complicated patients, they don't form the relationships that Elaine was talking about. It's well-intentioned, but operationally, I don't know about this concept of practicing at the top of your license. I just think there's a bunch of policy initiatives that are well-intentioned, largely well-intentioned, because we've got accumulating data that shows that the U.S. is a mediocre healthcare system at best. We spend lots more than anybody else, and our quality results are sort of in the middle. We do well in some areas, do poorly in other areas. We're not getting our money's worth. We need to do more, so policymakers want to do something about it. Most of it backfires. And in fact, if I can give a plug for Health Affairs in the December issue, when is the December issue out?
Monday. Yeah.
Monday, I do a book review of a new book that's out, which documents with great insight on a practicing physician all the counterproductive impact of well-intentioned public policy. What I also say in my review is that he doesn't have a clue about what to do about it. So measurement is, to me, one of the classic examples here. We don't distinguish nearly enough measurement for quality improvement, which is done by organizations, where you need to measure, which is theoretically in a safe environment. Nobody's publishing the results. And MACRA, which will supposedly put a rating on every doctor in 2019 based on their performance on a handful of stupid measures. Doctors don't respect them. They mostly don't measure anything important about a physician's practice, and yet the Congress, bipartisan, bicameral, decided that physicians, uniquely amongst all the professions, are going to be rated by the government. And MedPAC, I would point out, has recommended for eliminating the MIPS, which is where this. So I understand the impulse to do pay for performance, to do public reporting. At the level of the professional and practice, it is counterproductive. You get gaming behavior. And then finally, I said I spent my first 20 years practicing. I actually come from a family of physicians. My father was a surgeon. My older brother was a psychiatrist. I became an internist. I have a physician sensibility, even though I've spent 20 years in the policy community. When I sort of saw the PQRS measures for my specialty, internal medicine, I sort of I felt degraded that somebody would think that those stupid measures were some measure of my quality. And so this book, which again, you'll see a book review if you're interested, goes through a whole list of things, the documentation guidelines for payment, which he goes through a lot of it. We need the alternatives, though, and that's the problem, is we don't want to go back to the status quo ante when things were not working very well. So what we have is the profession correctly saying this is all intrusive and not very helpful, but not really being proactive in what's the alternative. So those would be my comments.
Yeah, Alan, maybe this is a better response to your earlier question, and it reflects on some of the comments of Dr. Linzer and the others, and the training of doctors. I think there is a relationship between joy in medical practice and burnout and health. So I think that if we can do things to promote wellness, like yoga and all that stuff, which when I wrote about my story, people wrote to me, yeah, my division chief said I should do yoga, and that's ridiculous, and it is ridiculous. But the point of wellness and a joyful workplace, a supportive collegial workplace, as Dr. Berenson mentioned, all of that supports physician well-being and probably health, because a less stressed environment will be a physically healthier place. So I think all of these measures which foster, happiness, if you will, and just even if you have angry physicians and angry staff and everyone's tired, that's not good. And I think they're not separable. So I think all of these measures, some of which are annoying and some of which may seem trivial, may bolster physicians' health, which then would bolster patients' outcomes, I suspect.
Other thoughts on the policy environment?
Yeah, sure. Totally agree, and I want to go back to one of the things that Dr. Kirch said about having measures that matter. About 8 years ago, Jane Lemaire and Wallace and team from Canada proposed in the Lancet that wellness was the missing quality measure. And I think it's taken us about 7 of those years to figure out that they were right. And now we're trying to figure out what exactly we want to measure to say that an organization or a workplace is healthy. But that really is why we did the Healthy Workplace Study, was to begin to develop those metrics. So I've been putting the finishing touches on an abstract for SGIM this year that will begin to propose some very easy to measure quality metrics of a workplace. So you know if that workplace is likely to produce doctors who are satisfied with their practice, who are connected with their patients, and you can measure the patients also just to make sure you're right. But these things are actually not that hard to measure. We've been doing it for a long time. But I think the time to make them part of policy discussions, time pressure during visits, chaotic environments, stress from the electronic record, alignment of values between clinicians and leadership, that the patient is what comes first. Those things can be measured, and organizations could be held accountable.
Let's turn to the education and training. A number of you have already alluded to it. We can go, I think, beyond sort of the first order comments that have already been made about the pressure, the sort of the heroic image, the need to be able to practice in teams. But what is the role of the academic medical center and the alignment, which Darrell, I think you mentioned? It doesn't do much good if you train one way and then the real world out there is totally different. How do we make that continuum better?
In broadest terms, I think the problem with education, medical education, but other health professions, is that we refer to it as the continuum of education, but it's the most discontinuous continuum you can imagine. What it consists of are a series of compartments: pre-med, basic science years, clinical years, residency, fellowship, separated by high-stakes knowledge-based exams. And the system tended to be designed to just teach to those exams instead of saying, what does the healthy, experienced clinician need foundationally to achieve that endpoint? And the innovation that's going on in medical education that I feel best about is that people really are starting to reframe education from the pre-medical level. We're moving more and more rapidly away from traditional natural and life science-based prerequisites to valuing the humanities, the social sciences, the liberal arts. We've changed the MCAT exam to reflect that. Schools now have holistic admissions processes that try to damp down the emphasis on test scores and grade point averages and look at things like distance traveled. You know, how far has this person come in their life to get where they are now? To embrace the sorts of things that not only, I think, lead to more humanistic physicians, but also more diverse people being accepted to medical school. And without going into the detail, I see efforts at every level. The ACGME at residency accreditation now has really started placing their emphasis on the learning environment, and in particular, the attention to well-being in that learning environment. So I feel that we're at a critical stage where the whole mindset about what medical training should accomplish is changing. I do want to speak to one point, though. We're not there yet. What's really distressing is there are now well-documented studies that show that if you take students accepted to medical schools, compare them to their peers who are not going to medical school, the students accepted score higher on measures of resilience and lower on measures of burnout. That is reversed within 6 months of starting medical school. So medicine is a stressful profession. Medical education is stressful. We need to just consciously acknowledge that we're all unindicted co-conspirators, in creating this problem, and we all need to take ownership in working towards solutions at all levels of the pathway.
Let me ask one last question before I open it up. Elaine was last in order, but raised some issues that I have a feeling others of you may want to weigh in on, having to do with the clinician's own experience and the environment in which having any sort of a medical episode can either play out well or not so well. And I just wondered if any of the others of you want to reflect on what it takes to create an environment that's not just better workflow and better satisfaction, but better accommodated to the reality of physicians' lives and their health. Mark?
That one relates a lot to my role as Division Director of General Medicine at Hennepin, where I have 65 faculty who report to me, and it's arguably my most important role and the one that keeps me up at night the most, because that's when you start worrying about the people. I try to make it clear that everybody in our offices, and we see 60,000 visits in a year in our medicine clinic and more in our other clinics, are incredibly important to me, and that I know that they have the opportunity to take care of their families and themselves and get out of the office sometimes and get a healthy meal during the day. And I watch it. And my door is pretty close to where the door getting out of the building is at night, and I'm watching to make sure people are getting out the door, and when they don't, I go back in and say, what's going on? How are we going to get you out of here? Why are you still at the office? I know you got people waiting for you. You need an environment that walks the walk of believing that the most important asset we have to give is ourselves. And that if we don't take care of that asset, we got problems. And this movement has, I think, sponsored many organizations that now do that recognize that every single person who works for us is somebody we have to take care of. And if somebody's having a hard time, we got to figure out how to be there for them so that they don't have to be the one to ask for coverage over and over again. We figure out a way to make it work. I think the last thing that got me getting on the plane was somebody was sick, they couldn't come to the office, who's going to cover the wards? And I was trying to figure out a way to get to the wards before I got to the airplane so I could be there to just make sure somebody was there and that they wouldn't have to worry about finding coverage. I think it's terribly important, so I appreciate it being raised.
So I would I finished my article on vertical integration by saying even though the policy judgment right now is that maybe this isn't the greatest thing for delivery system reform because spending is more, quality is mixed. I concluded, however, physicians do not want to go into, younger physicians do not want to go into independent practice, and here's a simple example. There's nobody giving you sick leave when you're in an independent practice to take a few months off for health reasons. For lots of reasons, I think younger physicians want to be employed and not be entrepreneurial on their own. So that, to me, then raises the whole issue of if that's going to be the natural trend, even if it's not what somebody designing the healthcare system would necessarily recommend, we want those independent docs. Well, they don't want to be there. How do we then incorporate the best of small independent practice, which again I would argue is built around relationships, the lack of bureaucracy, focus on clinical care, not on well, I'm trying to think of the term for it, but I don't have it right now, but sort of hitting bureaucratic milestones of improvement or whatever. In other words, preserve what works in small practice, but in an environment which has the supports for the individual physician and a system that supports the patients, which a small practice can't do. And increasingly, the need for that in clinical care is becoming clear as we've moved from treating patients with acute healthcare problems that you can do something and it goes away, to patients with multimorbidity, et cetera, small practices are not well designed to do that. So preserve a small practice, but within an environment of support.
And I actually think there's proof that what you're proposing succeeds, because if you look at systems like Geisinger or Mayo, Kaiser, they often have higher levels of physician satisfaction and engagement, and they are essentially, they're big organizations, but they're essentially physician-led group practices. That's their DNA. And I think there's a lesson in that as consolidation of health systems occurs.
Well, we've had a good conversation. I want to open it up for questions or comments. The gentleman here in the aisle, and let's get, we do have a video, so please wait for a microphone and identify yourself, please.
Joel Coopersmith from Georgetown University. Just picking up on some of the themes, nobody has said the word professionalism during this entire meeting. And they said profession, but not professionalism. And the professionalism is the concept that there is a special relationship that's different between a profession and the object of the profession, between a doctor and a patient, and a number of other professions. That is, I think, the reason most people go into medicine. And I think the central thing is that is being undermined by all of these new parts of the healthcare system. It's being undermined by the electronic health record, by quality measures, by the need for teams. All those things may be necessary. The need to reduce cost, the fact that most policy meetings start with saying how miserable the healthcare system is and it's the doctor's fault. And I think there is an inexorable conflict. It's almost a trade-off between doing these things and undermining the traditional concept of professionalism. And, you know, a lot of the things that have been suggested are really working around that margin. They help, but they don't get to the central core, which may not be possible.
Reactions?
Yeah.
Elaine?
May I speak to
Of
that? As I see it, physicians can be professional in a private, small practice setting or in a larger group setting. I don't see those.
I don't think that's the issue.
Well, there's a trend, as described, toward larger, vertical integration, and younger doctors are choosing less often to be on their own. From a physician's point of view, I mean, it's much safer to be in a large group. I think from a patient's point of view, it may be better in some ways to be taken care of by a large group of doctors if there is an institution in your community that can provide that sort of safety network. I don't see how that goes against professionalism. All right.
That's all right.
I mean, the profession, if you go to the Mayo Clinic, a hospital where I've never been, so I have no relationship there, presumably there are doctors there who behave professionally and have professional relationships and take pride in their professionalism, their work. The same could happen in any hospital or practice or not happen. But I think it's, I don't see that as the problem. I was going to mention that the one thing we haven't talked about is money. Because I think part of the problem is that there are division chiefs, people who get to be in charge of departments in medical centers, are not all so caring about the physicians and others in their departments. And so part of how they get to be in their position is by protecting their bottom line, which includes extracting more work, more value units, and more patients seen, and more infusions given by each physician. So I think, professionalism is one very important issue, and I think it's important to me as a patient that my physicians behave appropriately. But I think another big topic is money, that it costs a lot of money to provide physicians with a supportive environment and to hire, as we discussed, that's a separate issue. I don't see them as incompatible, professionalism in large groups.
Well, I'm going to take that one on. I was my citing of Fuchs was to raise the issue of professionalism. He talked about the body and soul of American medicine, and that's what I was referring to. I think there's a pretty good case to be made that professionalism has declined dramatically. A profession is supposed to do active peer review to protect the quality of the profession, and that doesn't happen very much. The individuals in the profession are supposed to be absolutely current on the knowledge base of what they are professionals about, and there's just been a lot of documentation of where that falls down, and they're supposed to act in the best interest of their client or patient in this case. And there's a lot of fraud and self-serving and other activities going on. So that's why I said earlier, what we've been trying to do to deal with these deficits is counterproductive, but to just go back and say we're going to just rely on the profession to function like a profession and manage itself, I think I don't think that's happening. So I regret also the reduction in professionalism, but I don't know how you sort of put that genie back in the bottle once it's out. In my own personal experience, I remember, this goes back now 20 years or so, when Len Abramson, who was the head of U.S. Healthcare, sold his shares to Aetna for tens of millions of dollars. The general reaction from physicians that I was hanging out with was, I want to get my piece of that also, if that's what's going on with our healthcare system. And so the pursuit of money, I think actually, which physicians may not have caused, but which physicians responded to as the whole health system became for profit, I think resulted in physicians' divergence, the willingness to deviate from ideals of professionalism, and that's sort of where we are. If you have some specific ideas about how to recreate or reinstill professionalism, I think that's what I was suggesting we need, because what we're doing right now is counterproductive.
Can I just say one sentence? One sentence.
We'll give you a sentence.
My point was that there, not that we don't have, not that we need to go back to the old days, but that there's an inexorable conflict between professionalism and some of these new things, and that's what we have to deal with.
Let's go down to Al at the end.
Good morning. I'm Alan Plummer. I am professor of pulmonary and critical care at Emory University. My question has to do with training, which we've addressed. If you think about it, we train medical students, interns, residents, and fellows in the hospital. And all of a sudden, when they have graduated, they have to go out into the practice world. And, you know, if people have looked at this, and if you're out in practice, you're only seeing less than 5% of your patients in the hospital, or you should be. That means that 95% of your patient is going to be in the office. I don't think we train our trainees to do much about setting up office practices. What are the stressors there? Because I'm sure the stresses of going out and starting your own practice are different than they are if you go into a already mature system like you might if you're going into a hospital-based practice or a big group practice. So I'm wondering what we need to do in order to avoid that, because I think burnout occurs at all levels, it seems like, in training. And certainly, once you get out into practice, there are different stressors there that we have to worry about that cause burnout.
Actually, the data show that steadily over the last 20 years, experiences for medical students have shifted from almost exclusively hospital-based clerkships to a mix of ambulatory and hospital-based. It's very common now for students to have longitudinal primary care experiences that go far beyond an individual clerkship. And a lot of this, depending on the specialty, a lot of this carries through into the specialty. Now the one reality is, whereas 20 years ago, the vast majority of medical students said they anticipated going out into independent practice, today a very small percentage of them say that. They know that they're going to work in organizations, and they read people like Don Berwick say that healthcare cannot remain the last cottage industry. And setting up a small practice is almost a cottage industry venture.
Can I make one comment
Oh,
on
of course, sorry.
I'm sorry, I don't want to interrupt.
No, but
I just want to share some thoughts about being from the ICU and critical care and pulmonary. One of my roles at Hennepin is I'm director of the Office of Professional Work Life, and we look over the work lives and wellness of the 700 providers at Hennepin County Medical Center, which is a level 1 trauma center in a very busy place. So it's a very busy job. I love it. But Michelle LeClaire is the head of our ICUs, and we did a project where we measured the work lives and wellness of our ICU providers, and we expected it would be very challenging because it's a very hard job. And it was some of the best and lowest burnout that we had in the hospital. And it was quite surprising. And so we dug a little deeper. She's going to be presenting some of this at the Society's meetings next week. But we found what I call this incredible combination of teamwork and values alignment, which might align with the professionalism. When you've got 100% on our scales of alignment of values with your leaders, and you've got teamwork that supports you all the time, it looks like you can do almost anything and not burn out. We had 4 ICUs, and then the rates were 20% or lower in every one of them. Some of them had 0. Despite giving beneficial care, non-beneficial care, all that challenge in ICU care, they still didn't burn out. So it gets back to a point that I always make, which is you need to understand the work environment. You need to know what's working about the work environment, and then you need to engineer that so it's working better. And whether it's out in practice, solo practices, large practices, small practices, academic centers, ICUs, primary care clinics where I work, if you understand the environment, you can do something for it.
so I'm going to do, I'm going to take the 3 people whose hands were up to each make your question, and then we'll bring them all back instead of going back and forth so that we can wrap this up. So we've got,
I'm Dr. Caroline Poplin. I'm a general internist. I was a lawyer for 12 years before I went to medical school at 40. I retired from Bethesda Naval Hospital because I was totally burned out. In fact, I had PTSD. I still practice at the Arlington Free Clinic, which has been a wonderful learning experience, and I practice law again. Research is all well and good, but we are not lab rats. We are professionals, and if you want to know why we are burned out, you need to ask us. I haven't heard anything about talking to physicians about what bothers them and how they think they can improve their situation. We're not experimental subjects, although the research is helpful. No one has said anything about talking to physicians. We're professionals. We expect to be consulted. We expect respect. And if we don't get it, we become shift workers. I published a piece on this in the Health Affairs blog post called The End of Internal Medicine as We Know It. I published in the NEJM Catalyst another piece about corporate stuff called Medicine is Not Manufacturing.
and take this. We're just going to do all 3 so that we
Okay,
can.
I'm Doug
get-
Tyner from the American Psychological Association, and I've actually worked and had medical staff appointments and faculty appointments in medical schools for close to 30 years, so I've been a voyeur of the system as a psychologist. My one question is, we have other high-stress occupations and professions out there, ranging from airline pilots to public safety, and they've all built into their systems ways of managing stress and handling a critical event. If a police officer is involved in a shooting, they immediately go on paid leave for 2 weeks, regardless of what happens. And there are lots of examples like that. When the Navy stressed the 7th Fleet, we started seeing accidents, and they fired the CEO, which never happens in a hospital. So I'm just questioning why we're not looking at other professions and learning from what they have to offer.
And if you can get Mike behind.
Thanks, Helen. Mike Miller, I'm a physician. And Elaine, before I ask my question, I want to thank you for telling your story. I started my internship in 1986, so I think we're sort of contemporaneous, and in that environment was an interesting time. So thank you. My question is a little more in the policy world, which is where I've been living for the last several decades, and about the status of the professional, not always professionalism, but the independent professional and the clinician, and getting a little bit outside the box, because I see sort of the world we're now living in devaluing that individual profession, and I'm not just talking about clinicians. Whereas if it's not scalable, if it's not measurable, if it's not expandable, very techie tech kind of stuff, then it's kind of devalued in our current economic, social environment. So I don't know if anybody can talk about how to, I actually want to make the point that I think it's very important to understand that, because we're going to come up with solutions to how to reinvigorate the individual clinician's experience, life, wellness, address burnout. You've got to understand the general cultural, social, economic environment that we're operating in. Thanks.
So I know it's a range of topics, but maybe some of you want to pick. I do know there's been a lot of research listening to physicians, so maybe we should start there, but let's try to bring these together.
Yeah, I'll just say I completely resonate with what you're saying about talking. And so that is how we started our research, was we did focus groups, and we went into clinics, and we went to doctors, and we sat down and we just listened to them. And in fact, all of our surveys came from the words of the docs. So the word that we use about the chaos scale was completely, I still have those quotes written down of, this is what my life is like, you have to help me. And now my job now mainly is listening. There's a book about what patients say, what doctors hear, by Daniel Offrey from New York, which is spectacular. I'm in the middle of now. And it's about the chief listening officer. And that is what my job really is to listen. So thank you for raising it. I'm sorry, please.
No. I actually think your point about learning from other industries was something we saw in the quality and safety movement, right? We focused on issues of how to do things like checklists, which were picked up from other industries. And so I see activities that are like that, of how the military, of course, has to deal with all the repeated deployments with tremendous levels of burnout, loss of resilience, depression. So there are opportunities there, and I hope that's one of the things we can do. I want to go back to the note you struck about professionalism or the independent professional. I would argue that some of our problems is that we descended into being so focused on our autonomy and our control and our scope of practice that we lost sight of the fact that there is real joy in terms of being part of a high-performing team. And that's what your ICU data, Mark, really verify. That when you can create interdependent professionals, they can function at a much higher level than independent professionals ever could. It's part of the reason that the airline industry doesn't, that they develop crews, and crews know their roles, and they support each other. So I rather than, I have a colleague who says that many of us in medicine spend far too much time longing for a fondly remembered past that never really occurred. I think what we need to do is start thinking of what does this new interdependent professional world look like when it performs well, when you have experienced, healthy professionals that work in that team.
Elaine?
I might offer, I was thinking about what Mark Linzer said about caring about the people in his department. I mean, ultimately, I think we need to draw physicians who are leaders, who care about the people who work for them. I mean, when the person who knew me left, that was one of the bad luck things that happened, and I don't blame him in particular. But I think, drawing people who are, like you talked about, the non-sciencey aspects of good doctors. I think that the medical schools could do a better job at drawing people who are good at both. You know, there's a lot of emphasis now on drawing women and minorities into STEM, but the reality is, well, I want doctors who are good at math and science and who are really nice and effective communicators. I want it all. And that will lead to better environments. I mean, I used to have fun in the ICU. You're right, I think there's a team there. It doesn't surprise me, that result. The team, the caring among one another. If something happened in a team of doctors, the others would want to help out. It's in general doctors' natures to do so. So I'm optimistic that we can figure this out. But I think it involves drawing people into the profession who are nice, like you say, and also who are capable of figuring things out.
It's interesting, if you talk to med school admissions officers now about what makes a good future medical student and doctor, one of the things they look for are people who've done Teach for America, which I think really talks about somebody who cares about the human side of the lived experience, especially for people who are not so privileged.
Well, I'm not going to try to summarize this robust discussion, but I am glad that towards the end we moved into some more positive cast, because it is easy to get dragged down. I think there's no question from the comments here and the other literature on this subject that we're in the midst of significant change in practice environment, change in regulatory environment, change in technological environment. We know from every field that that kind of change creates stress. What was nice, I think, in the conversation this morning is to see some very thoughtful responses to that change. We aren't going back, but we do need physician leadership to guide that change so that it's more productive. But at the same time, we also need people focusing on the site of practice and bringing joy to it and attending to the people in it. We need teams to be high performing, and for people, I love the thought of reconceptualizing professionalism as a member of a team. That's exactly, that is fulfilling, but it's a different kind of fulfillment and not necessarily what people were trained for. And of course, there are generational shifts here. These changes are hitting different people at very different points in their career. So like the 18 years since To Err Is Human, we have a long road ahead of us on this, but I think the comments today suggest how much progress we've already made. So I just want to close by thanking the Physicians Foundation for supporting the publication of the papers as well as for this event, and most important to thank our 4 terrific panelists for their contributions today.